So
Yes.
I'll be talking about orbital inflammatory disease. Uh, so for first thing is that we need to understand what is orbital inflammatory disease. It is an open-ended non-diagnosis where a definite cause for the inflammation is not known. It is not I mean, unfortunately, what is happening is that it is being treated as a waste basket bin where everything and anything that doesn't make sense clinically is being designated as orbital inflammatory disease. So IOID is idiopathic orbital inflammatory disease. NSOID is non-specific orbital inflammatory disease, both equally non-specific and idiopathic names. And I'll try to explain why. So first thing is that inflammatory disease is a tissue response. It's not a disease. Also, response to steroids is not a diagnostic criteria. And there are many conditions that present as inflammation and that respond to steroid, including some amount of response is seen in bacterial cellulitis. That doesn't mean that is inflammatory, orbital inflammatory disease. So in cases that present with what is called typical orbital inflammatory disease, a systemic cause or an association must be investigated. And when we say must be investigated, it's ideal that it be thoroughly investigated with a rheumatologist on board and find a cause, because when you know that it is with in association with an autoimmune condition, then it is you have a clear nature or a clear association. Only when you don't find a cause, you can then call it an non-specific orbital inflammatory disease or idiopathic orbital disease. Now, what does this include? This orbital inflammatory disease can affect any of these structures that we see: the lacrimal gland, the extraocular muscles, the optic nerve sheath, the fat within the orbital apical structures, or even the periscleral tissue around the globe. And these are not mutually exclusive. You can have overlapping structures being associated and therefore a complex presentation. So typically, how does it present? I'll cover three clinical scenarios that we commonly see. Lacrimal gland association. This can be unilateral or bilateral, but more classically unilateral and sequential. Pain is typically seen, although rarely it can be painless. The course is acute to subacute, and classically you see an S-shaped eyelid that you see here. Again, subjectively, in terms of complaints, you have patients, like I mentioned, across the spectrum. Patients who are absolutely painless, in which case it more likely could be a viral dicryoadenitis, or in patients where there is, there can be severe pain as well. Myositis typically is unilateral, presents with pain and associated, motility and functional restriction of the muscle, which leads to diplopia, congestion, and chemosis. This is how typically the patient would present. You can see in the CT scan, there is a lot of preseptal edema and inflammation, along with thickening of the extraocular muscles and the lacrimal gland here as well. So it's not always mutually exclusive, like I mentioned earlier. The horizontal recti are typically more affected. There is always usually normal bone, and spillover inflammation into adjoining structures can be commonly seen. Differentials for this can be thyroid eye disease. As you can see, this mimics a lot of active congestive thyroid eye disease that Dr. Tarjani showed. Orbital cellulitis or metastatic lesions in the orbit. Diffuse orbital inflammation. It can be unilateral. It usually is unilateral, and patients will have a history of repeated episodes on and off. There is severe proptosis, ophthalmoplegia. If there is associated perineuritis, there is a significant visual reduction. And here again, your differentials can be thyroid eye disease, bacterial cellulitis, and because there is so much congestive inflammation seen, a CCF can also be suspected, and you need to rule these three things out as well. So what do you need to do as an investigation? So here radiology is important. Radiology can, typically be, I would prefer now an MRI or even a CT scan can give you a good guide, because you are able to visualize structures like the lacrimal gland, the extraocular muscles, and the optic nerve even on CT scan. So on MRI, what do you see here? You can see isolated inflammation of the lacrimal gland, which is enhancing with contrast on the right. Again, you can see the extraocular muscles, they appear thickened in size and enhancing with contrast. Here, especially the superior rectus, which is appearing so hyperintense because of the contrast uptake. Diffuse intraconal disease can be seen very well. And here again, you're seeing intraconal fat standing along with thickening of the extraocular muscles, which is very, very typical of this condition. Perineuritis with contrast enhancement, you see a ring around the optic nerve. Also, you can see a dilated SOV along with thickening of the extraocular muscles. Here you are also able to see the the episcleritis as a form of manifestation of orbital inflammatory disease. If your MRI doesn't reveal anything, then you should, and if the radiologist suspects, an angiogram can also be done to rule out CCF. On CT scans, findings are a little non-specific because it can be hyperdense, iso to hyperdense, irregular intraconal, extraconal lesions where your anatomy may not be that clearly visible. This is a patient I'll come to later on, but you can see the amount of thickening of the lateral rectus and inflammation along the lateral wall of the orbit. This again is a patient, same patient who had a CT and an MRI, and you can see that the clear delineation of the inflammation in the sclera along with the retinal detachment and the perineuritis or optic neuritis is very clearly visible. So how do you investigate, and when to investigate, and what do you do? Your classic investigations would be hemogram, CRP, your thyroid profile, and you need to make sure triple H is done to make sure that the patient is not immunocompromised, and infectious focus, including tuberculosis, is ruled out before you can start treating them with immunosuppressants. Your basic panel of serology is ANA, ANCA, HLA-B27, serum angiotensin converting enzyme to rule out sarcoidosis, and serum IgG4 levels. These are what the laundry list of tests that usually are done. Now, if it is mild disease, your diagnosis can be clinical, and you may give a trial of non-steroidal anti-inflammatory drugs. If it is classical disease like the three patterns that I mentioned, where patient may have pain, there is diplopia, typically for the horizontal recti, and proptosis, then is when you do your basic lab testing that I mentioned earlier, investigate the patient, and start on oral corticosteroids with a controlled taper. Consider steroid sparing agents only if their patient is not intolerant to steroids. And if it is atypical disease that doesn't fit in the pictures that we discussed, where the pain can be severe to even debilitating, but there may be very little diplopia, or active inflammation may be absent, but the patient has signs of proptosis, etc. In these cases, you may want to consider an incisional biopsy as well. Also, an incisional biopsy can be considered at any presentation, because in the end, if you have a tissue diagnosis, it is always good. How do you manage? Do you always give a trial of steroids? No, because a response to steroid is not confirmatory of idiopathic orbital inflammatory disease. Do you biopsy all patients, or do you see only typical or atypical cases? So literature tells that the classic presentation is abrupt onset, pain, periorbital edema, erythema, chemosis, and even diplopia, proptosis, and vision loss. This is typically what we see, and therefore this algorithm will help you. Once you image, once you've done your investigations, and then you can give a short course of systemic corticosteroids. And if you get a good, rapid, sustained response, you taper it off, and that would be the end of it. However, if they don't tolerate, you should then consider intraorbital steroids, which have a short duration of action, and possibly a biopsy. But if there is poor response, then you should definitely consider a biopsy, because then you're working with something else. And this is where your rheumatologist comes in. So in your atypical NSOID, where it doesn't fit the classical symptoms as well as imaging findings, your threshold for biopsy has to be very low. And treatment of this is always in conjunction with a rheumatologist. Sometimes you may have to think out of the box for treatment options. This is a patient who came with repeated episodes of orbital inflammation. You can see the amount of proptosis, chemosis, the extraocular muscle thickening. She had a history of a lateral orbitotomy earlier. You can see from the lateral orbital rim, there is some bony changes there. And a repeat biopsy was done. It was sclerosing non-specific orbital inflammatory disease, or IOID. You can see that in the image above, which is at presentation, and the image below after a course of IVMP, that the response was good. But again, she would come back periodically with worsened disease, Again, these are pictures over different stages where she would go back into improvement and come back again with worsening disease. And finally, she was put on azathioprine. However, this was a young patient who wanted to get married and conceive and have a child. So we had to take a call on stopping disease. We went ahead with low dose radiation to the orbit, and that worked wonders for us. This is on the left, you see the stages of multiple, disease quiescence and activity that she came. And this is a final follow-up after receiving EBRT to the orbit. So sometimes, we may have to think of different things. To summarize, a trial of steroids is not completely wrong, but do not undertreat it. Whenever you suspect things, anything atypical, biopsy it so that you can able to rule out conditions that can mimic it, like lymphoma. IgG4 is something that you should always add, because IgG4 disease has systemic implications. Patients with IgG4 related disease have a higher chance of systemic lymphoma. The biopsy is also required because you need to know what you are dealing with, whether it's a sclerosing variant or not. Sclerosing variants typically don't respond well to therapy. I'm finishing up in 30 seconds. This was a paper that we had published where we did IgG4 staining on all cases of idiopathic orbital inflammatory disease retrospectively. And we found that almost a third of all patients who were treated, who were labeled as regular non-specific orbital inflammatory disease, were actually IgG4 positive disease, which, like I mentioned, has systemic implications as well.